If you look at the status of newborn health in India, more than 7 lakh newborn infants do not survive beyond 28 days of life every year. And the newborn mortality rate is nearly about 22 to 25. In different states, it varies quite a lot, with some states doing very poorly and some are doing reasonably well. The graph of newborn mortality rate, as you see here in orange, has been coming down over the last 20 years, but not as fast as one would expect it to be. What are the causes of this newborn mortality rate? There are various ones, but you look at prematurity as one of the leading causes of death. Of course, that could be related to infections in the prematurity as well as other problems like problems during the birth and congenital anomalies. What is not shown here is the quality of the care. That could be one cause which might lead to many deaths or poor outcomes in the newborns. So what are the challenges in the delivery of services? To deliver newborn intensive care services, you need infrastructure with the place and equipment geared up to provide the intensity of the care required by these newborns. Of course, the human resources, the healthcare professionals are extremely the backbone of these services, and management to support the services. In the human resources, you definitely need the number which are defined by the intensity levels in each newborn unit must be available. Otherwise, the quality of care will suffer. You need expertise in managing these extremely sick newborn infants. Not only that, you need to have ongoing training programs to improve the quality of the care. Human resources is the main focus, where you need to build the teams, recruit the adequate number of nurses, and doctor leaders should be developed and nurtured. Training wise, there are many training modules available, like a PNC module, online group training, and on-site assessments. But combined together with the training and technology is the focus that I'm going to be talking about. Increasing the access through connecting the healthcare professionals using technology. That is the idea. Essentially, to just think about NICU or anything tele, before that you need connectivity. You need more information on the ground from the on-ground situation, what is happening. That can happen only through technology. The first challenge that we faced was, availability of clinical information to the experts. Currently, mostly it's the paper-based clinical information written, and you will not be able to know what's happening there. So we started by looking at digitization of the clinical records. That's where our application we made, where the machine information, the nursing notes, the doctor notes, parent communication, and images and other files were combined together into a nucleus, and that is the application that we used. That replaced the papers, and nurses and doctors started to use that. And just a brief of that, it's just a mobile application, cloud-based, where you can have all the clinical information in one place. As you notice, with more and more use of mobile phones, nurses and doctors feel more comfortable in using these sort of applications. So by using such applications, we observed a reduction in the prescription errors, which can be lethal in these small infants. And of course, we were able to access the clinical information, live clinical information from anywhere. And it did help to improve the availability of clinical data, which we published as a poster. Now the training, that's an extremely important aspect of it, which is first you provide the scientific education and basis of clinical diseases or the treatments. This could be direct one-to-one or in a group physical training in a workshop module. Also, there are online resources developed by AIMS group from New Delhi, and many nurses benefited because of these kind of online modules as well, where they could understand the basis of diseases and the treatments and standards. Apart from that, ongoing engagement has been carried through, especially in the last 1.5 years, through social media applications like Telegram, where again a modular training also can be followed up by mentoring and discussions, group discussions, which again has been pioneered by the AIMS team. And for after that, so once you have a knowledge and once you are clearing your day-to-day practical queries, you need to ensure that that is happening on the ground. So that is the testing and simulation phase, where we use the AV resources for skill testing, especially for specific procedures. So this is one of the very popular online modules, interactive group learning, led by Dr. Ashok Derari, through Telegram based, and thousands of nurses around the country have been getting trained through these modules. So after that, what we followed up was the remote simulation and assessment of skills. As you could see, from distance, you will be able to assess whether the delivery of the care or the practice is correct or not, whether the chest is moving with the bag and mask ventilation or not, which is a key factor in doing the resuscitation. That could be done, and the feedback can be given to the nurses and doctors. Also, we are looking at further advances like self-learning and practice using the voice-based interactive applications. As here you could see here, the application talks to the nurses or the doctors, and based on their responses it will give advices. This again still in the testing phase, but we are seeing a good response for a practice of the skills. Now, this is about the training, but after the training, again, the gap between knowing and implementation always remains in healthcare, and that's a major challenge for most of the centers, more so with the places that we are talking about in the outside the city limits, towns and tier 2 cities like that. So using again a simple webcam and connectivity, we were able to, after the training, observe and provide feedbacks for appropriate practices. Mind you, all of these processes will contribute to a better care for the newborns. So one by one, stage by stage, we are trying to improve the quality of the care through use of the technology. So that was one mode of feeding. And then the next level, we started looking at, okay, how is the hygiene part? Can we improve that? So this is another procedure called tube feeding, where the newborns are fed through a tube directly into the stomach, where the milk is fed because the newborn is not fit enough to take the feeds directly. And also the other major cause of mortality or morbidity in newborns is infection. So one of the tough procedures is maintenance of the central lines and how aseptically nurses use infusions. So there's one technique called as the ANTT, and after the training we were able to guide them, monitor them using again simple webcam and connected applications. So essentially, Delhi NICU is the end services, but prior to that, you need to prepare the ground with creating the team, training, and using the technology connectivity. So the essence of that connectivity is the newborn is there in the unit, a nurse is present on the ground, and they have machines and their clinical information which are connected. Now, the local doctor is important and very essential part of this connected care. However, they have multiple tasks that they need to do. That's where we can help them in managing these newborns. So it could be continuous monitoring, or it could be just the intermittent ward rounds as well. We could inform the nurses of any emergencies when you notice, and supervision of procedures as I just now demonstrated. And if there is a major issue, the nurse can continue to monitor and give the treatment, while the tele team could inform the consultant and keep updated status to him and give him clinical reports as such. So what we call this as a lifeguard services, where NIC ward rounds is done by the consultant, the care plan is developed by them and documented in the application, and lifeguards gets activated, and monitors could be connected in the from the on-site to remote areas, and any concerns in the vitals, and the nurses could be informed as well as the consultant on the ground, so that appropriate action could be taken. As you see, this one of the babies monitored remotely. Depending on the type of the camera that you use, you could get a very good understanding of what is happening. However, it is essential that the on-ground nurses and doctors are trained as well. Also, the monitors which are connected to the baby could be remotely connected, so that you will get the data continuously and live data. This is one of the companies called Massimo's patient safety net that we had used in the past. And there are other companies which are able to connect most of the machines so that remotely you can access the information and take appropriate action or give suggestions to the on-ground professionals. In the past few months that we've been delivering these services, outside the city limits, there are occasions where, middle of the night, unexpected problems to occur, where we had to intervene and advise and monitor during the care process, during the emergency. As you could see, a small baby's delivery, and the team were providing the resuscitation for the newborn, and our doctor was advising them what was the appropriate action. So like that, there are case studies. However, we generally are currently doing daily rounds where the remote consultants ensure the high standards of care is implemented, and we have seen reduction in oxygen usage, moving and also moving from head box to nasal prongs, like that better standard of care. Rationalizing the antibiotic usage. This happens because one is the awareness, second one is because of the training of the nurses, the confidence of the local doctors also improve, and then the unnecessary antibiotic usage is not done. And of course, you can prevent the prescription errors by using the applications, as I mentioned before, helping in the golden hour management of the preterm infants or any emergencies. And second opinion for the complicated cases as well could be obtained for anywhere. It could be a specialist, like a super specialist, like a neurologist. You could connect to them and get their opinions as well. And there were occasions where the troubleshooting for the machines, like CPAP machine is not delivering the pressure, or ventilator is giving an alarm, and the on-ground nurses or doctors tend to get worried, because if you don't see these problems very frequently, there's always that anxiety which comes in. That also could be addressed through this these kind of solutions. So the challenges, of course, as with any change, there's huge resistance to change from existing situation to the next stage, and it's many times it's felt that it's easy to transfer the care or accept moderate quality of the care. Cost of the software and the machines definitely plays a major role, because newborn intensive care is generally felt to be very expensive, and also depends, like different places have different cost structures. Some may be lower, but some may be very high. But adding again the software cost to that can lead to increased burden to the patients. Availability of trained personnel for remote management as well is important, and a challenge as well, because that's not a normal career that one pursues. So there has to be both balance of them working on the ground as well as for a remote management. And internet connectivity on the ground is extremely important. It's continuously the internet is getting better in the towns, so we're hoping that we'll be able to connect better. And acceptance by patients is extremely, again, important. So what is the way forward? Definitely technology as a tool will help us improve our quality of the care, and more engagement with the medical community and management will help us for delivery of smooth services on ground. Partnership between various stakeholders to improve the care provided to the newborn, like it could be equipment manufacturers, it could be software providers. So different people working in this space could come together to ultimately ensure that the quality as well as the cost of the care are to the expectations of the patients. And that is the idea of connected care, and better quality of the care for the newborns who are not in a place where they can access high quality of healthcare professionals.
This is our overview of our products, and today we'll talk about blood gas analysis and transcutaneous monitoring. We're a company which focus on acute care testing solutions and parameters. We're part of a very large corporation called Danaher Corporation. It's within Fortune 150 group, science and technology innovators. And you can see that we are in a group with very reputable companies. We are all the same family. Right now in radiometer, we have around 4,000 colleagues, and we have direct representation in 33 countries. In India, recently we get into partnership with GenWorks, and we hope that we'll be together. We will be able to offer hospitals and especially neonatal intensive care units state-of-the-art solution covering both blood gas and transcutaneous monitoring. So talking about blood gas and transcutaneous, we're focusing on two of our instruments. One is Able 90 Flex, and this is very basic data, but very important as well. You are getting results in 35 seconds, and you need practically only 3 drops of capillary blood, the whole blood. And you will get 17 critical parameters out of it, directly measured. Now, TCM-𝐂𝐐𝐬 is a transcutaneous monitor which allows you a real-time trending of transcutaneous blood gases. And there are some features which makes use of this analyzer easier. It is automatic calibration, smart heat, and so on. These are details for more focused presentation. Very brief overview, what you are getting out of ABL90 Flex. These are the parameters which are measured, and I highlighted here in red parameters which can be interesting for, especially interesting for neonatal departments. This is bilirubin, this is methemoglobin. If you are using nitric oxide in your department, then you have to keep eye on methemoglobin levels to be below 5% of total hemoglobin. Fetal hemoglobin also in some cases is used when you are doing exchange transfusion, for example. In addition to all these directly measured parameters, you are getting over 40 derived parameters. Of course, you will not need all of them, but depending on your profile or depending on patient's situation, you can select which parameters you want to be displayed or printed out or transferred to hospital laboratory information systems and so on. Instrument also is battery operated, so in case of power interruption or if you need to move instrument from one place to another, it can work on battery and measure within 1 hour period. TCM-𝐂𝐐𝐬 is the name of this particular model of transcutaneous monitor. It measures transcutaneous O2, transcutaneous CO2, and also power supplied to electrode to keep temperature constant. Of course, the main parameters here are oxygen and carbon dioxide, but in some particular cases you can find power also a useful parameter. It calibrates automatically. Again, in case of patient transportation or power interruption, it automatically switches to battery, and it has basic onboard data management capabilities. Now let's go a little bit into theory and look what we are actually measuring and where transcutaneous measurement stands. So we have 3 basic methods for measuring blood gases. This is a gold standard, arterial blood gases, pulse oximetry, and transcutaneous measurement. Very general characteristics. Yes, blood gases are gold standard, but it's an invasive method. And if we are talking about PO2 and CO2, especially PO2 arterial, it reflects the pulmonary oxygen uptake. If you have more advanced instrument, which measures different hemoglobins and other parameters, then you can get a picture of oxygen transportation following the uptake and oxygen release to the tissues. And also modern blood gas analyzers, as you saw in previous slide, measure a lot of additional parameters, metabolites, electrolytes, and so on. SpO2, which you are getting from pulse oximeters, This is not exactly the same as SO2 saturation, which you are getting from blood gas analyzer, but basic calculation formula is the same. So big advantage of this method that it's non-invasive. It reflects utilization of current oxygen transportation capacity. It's continuous, but you don't have carbon dioxide in monitoring. And because of physiology, because of shape of oxygen dissociation curve, you cannot detect hyperoxia, which is extremely important to avoid in newborns by pulse oximetry. It's not a deficiency of methodology or technique as such, it's just physiology, this oxygen dissociation curve, which does not allow you to detect high PO2s on very high levels of saturation. Now, transcutaneous oxygen and transcutaneous carbon dioxide. We're monitoring gases which are leaking through the skin, reaching electrode surface through the skin, and it reflects the distribution of oxygen from arterial blood to tissues. It's non-invasive, continuous, it's not substitute to blood gas, but it's very good supplement, as well as very good supplement to SpO2. Quite often we are getting questions about difference between transcutaneous monitoring of blood gases and saturation. And difference is quite significant because both of these groups of parameters reflect give very important information. But saturation shows us how well we are using available resources. If you look on definition on formula, you can see that we have oxygenated hemoglobin divided by the sum of oxygenated and deoxygenated or reduced hemoglobin. So saturation deals with only two states of good healthy hemoglobin, oxy and deoxy. So it shows us how we're utilizing resources, but it does not give us information about these resources as well. But transcutaneous oxygen and carbon dioxide, they are measuring actual gases, physical molecules, which are reaching skin surface. So this is another way of presenting this concept. So on one hand, we have arterial blood gases, which reflect oxygen uptake, transportation, and release to the tissues. On another hand, we have transcutaneous, which actually measures how much oxygen is reaching the tissues. Where transcutaneous is used, it's not only neonatology, and as I told you, it's not a new method, so it's very well established in all these segments, in adult respiratory departments or ICUs. Very large segment is sleep studies, and also diagnostic segment, we call it diagnostic in wound care and vascular area. But around 50% of all our TCMs are placed in neonatal ICU. Acceptance of this technology differs very much from country to country. I can mention that very, popular transcutaneous monitoring is in Germany, France, US, Russia, Japan, but in some countries it's relatively new technology. Why ventilation and oxygenation monitoring is so important? Of course, in this short presentation, we don't have time to go very deep. and probably you know better than me why this is important. Just to highlight that preterm neonates are very vulnerable to alterations in arterial gases, oxygen and carbon dioxide. And in some situations, it's crucial for the survival of a newborn to get this continuous information. What are the challenges? A lot of challenges. There are no ideal method which will fit all situations. For example, because of very low blood volume in neonates, we as a manufacturer are forced to deal with very small volumes of sample. Like I mentioned on AGL-19 flex analyzer, it's only 65 microliters, which actually creates a lot of technological problems to manipulate this small volume of blood without dilution and without affecting measured parameters. Neonates exposed to painful procedures like punctures, they increase the pain scores and the alterations in oxygenation and heart rate. And actually you can see it if you are taking blood, capillary blood from the heel of the baby and simultaneously monitoring with transcutaneous monitor, you can see change because of pain on the curves. I want to show you a short animated clip which is quite well done, and I hope it will help you to understand better what we are actually measuring with transcutaneous.
Continuous and non-invasive monitoring of blood gases. Transcutaneous monitoring provides critical data about a patient's ventilation and oxygenation status when frequent invasive blood sampling is not adequate. When you breathe, oxygen is transported from the air into your blood vessels via the lungs, and carbon dioxide is released. The heart pumps the oxygenated blood into the body's circulatory system, where it provides oxygen for all vital processes in the body. The cardiovascular system transports the carbon dioxide that is produced during cell metabolism back to the lung, where it is exhaled. Inside the skin's capillaries, the blood flows just 1/10 of a millimeter below the skin's surface. The transcutaneous sensor is placed on the skin, where it elevates the temperature in the underlying tissue slightly above body temperature. The body reacts by letting the skin breathe, allowing for gas diffusion through the skin. The sensor registers the quantity of oxygen and carbon dioxide present in the blood. If the levels of oxygen and carbon dioxide in the body are out of balance, this could indicate that one or more of the body's vital functions are altered and that the patient's condition could worsen rapidly. Continuous monitoring allows for a fast response to changes in patient status and for timely intervention to ensure the best possible patient care. Let's look at the clinical settings where transcutaneous monitoring makes a real difference. Abnormal oxygen and carbon dioxide levels in preterm neonates can lead to severe cerebral damage and eye and lung complications. Transcutaneous monitoring allows for immediate detection of changes in oxygen and carbon dioxide to ensure a better outcome. For patients under non-invasive ventilation, it is vital to have real-time data on ventilation and oxygenation status in order to allow proactive ventilator manipulations and tailored therapies. In sleep labs, Transcutaneous monitoring supports the diagnosis of sleep-related hypoventilation syndromes and helps create an undisturbed sleep environment for patients. In the ICU, where every minute counts, continuous monitoring offers a reliable approach to accurately titrate ventilator settings for patients with acute respiratory failure. During anesthesia, transcutaneous monitoring continuously keeps track of carbon dioxide levels to avoid complications in sedated patients. For patients with severe wounds, transcutaneous monitoring is used to assess healing probability, adequate amputation level, and treatment effectiveness. Transcutaneous monitoring provides continuous and non-invasive monitoring of blood gases and offers proactive rather than reactive intervention to critical changes.
So I wanted to show you, it's one of our old presentations, but I think it reflects very well situation with and without transcutaneous monitoring. So first of all, you are getting continuous information on oxygen and carbon dioxide. It's early, precise, and fast warning about changes, and you may reduce dramatically number of blood gas samples taken from the patient. You will take this sample only when you see on the screen of monitor that something is happening. And this way, you are not only reducing number of samples, but also increasing the value of each sample, because you are taking it not according to schedule, but according to changing the patient.
Introducing an e-learning course on blood gases and transcutaneous monitoring in the NICU and PICU from 𝐂𝐎𝐍𝐶 Checkpoint, endorsed by the European Society of Pediatric Neonatal Intensive Care and the European Society for Pediatric Research. With no cost to access, this online educational program focuses on TCM in the NICU and PICU, an interactive training course that aims to demonstrate the added value of TCM parameters, indications for TCM, as well as its practical application, and how to interpret TCM results and act upon them. With simple online and mobile access, this self-directed learning resource is designed to fit around your busy schedules, whether sat at your desk or on public transport. Aimed at neonatologists, pediatricians and nurses, along with respiratory therapists working in the NICU and PICU, delivering dynamic and engaging content through animations, videos, interactive clinical case studies, and ongoing knowledge checks. Developed by a panel of international experts in neonatology and pediatrics, this e-learning lasts around 60 minutes, with CME credits awarded by 𝐂𝐎𝐿𝐼 upon successful completion of an assessment test. The blood gases in the NICU and PICU e-learning also features downloadable learning resources direct to your desktop or any mobile device. No cost to access when you register on the 𝐂𝐎𝐍𝐶 Checkpoint platform.
Thank you very much. That's it, I think, for today. I hope you found something at least interesting in this presentation. And if you need any additional information, please don't hesitate to contact us, Radiometry India, or our partners, GenWorks, and also these web resources which to do.
So it often felt like, did COVID open a Pandora's box in healthcare? Even the most compelled and health infrastructures, with most of the resources were grappling with crisis in the last 2 years. And often whole disruption was brought to specifically people not only affected by COVID, but people who were having chronic conditions which needed continuous interaction with their doctors and healthcare systems, which led to a major disruption and a significant amount of dissatisfaction among the healthcare providers and the patients because of this disruption. Often, not only COVID, but because of the uncertainty, because of the volatility, because of the complexity, and because of the ambiguity, the challenge of delivery of healthcare was often very, very difficult, even in these challenging times. What makes it more complex is that we have the least amount of hospital beds and medical workforce per 1,000 population, as this is the data from the WHO health platform. There is a significant disparity between the public and private health, as there are only, you can see, 0.3 beds per 1,000 population, which is available. This challenge is often very complex, but India is a vast country. We deal with volumes, and there are numerous stakeholders, which each one of their own perspective. So if you look at the slide, though most of the 66% of India's population lived in rural areas, our healthcare spend is lowest, and 60% of these patients who lived in the rural areas wanted access to private healthcare. So it makes it very complex that most of the beds in private healthcare are in urban areas, and the population is distributed in the rural areas with limited access to private healthcare in the rural areas. So this is another challenge. As I said, there are numerous stakeholders. There are decision makers, which could often be patients' relatives, the community, opinion makers. There are clinical decision makers, which are the healthcare providers, the doctors, and we are trying to access or bridge the gap with information and technology. Though in the last 2 years, healthcare information technology has come leaps and bounds with remote monitoring, artificial intelligence, as you can see, a lot of IoT devices, electronic medical records access, digitalization, change management, asset tracking, and a lot of new things which are coming to make the life of the healthcare providers easier. But even with these challenges, there is a gulf between thinking and doing. We often struggle to convert ideas into outcomes. Though decision makers have their own perspective, there is a significant amount of anxiety and information gap. During the time of admissions, there is no information often, there is a knowledge gap, and most of the people have to access urban areas, uproot themselves from the rural areas. A lot of new systems like digital lockers, process ideas like apps, giving RFID tags, mapping of patients and doctors' visit to the beds, video consultations have often helped and been able to bridge the gap. But as I said, we are a volume-based country. Is this a unanimous process around the whole healthcare system? Often it's seen not. It's only the few and far between who have access to this kind of technology or who can afford the healthcare systems which can provide this kind of technology. The clinical decision makers have also had to face challenges. There has been training gaps, skill upgradation required. Antibiotic stewardship is often a significant amount of problem in critical care, which has been more challenging in the last 2 years. Clinical pathways have been developed, workflow streamlining has been done, but Clinical decision support systems are not aligned throughout the healthcare systems. There are often communication errors, and right now there are no benchmarking between healthcare systems throughout the whole country. Though in the last 2 years, we have become a significantly digitally connected society. So a lot of people have access to digital healthcare, or digitalization, change management has been done by the country. So this talk is about connected care. But what is a connected care network? It is not only providing care, it is to take a holistic view of care, to nurture innovative approaches in care and support, to involve all the stakeholders who want to work together more closely to provide care, and to provide an independent and authoritative voice which promotes investment in new models of care and can manage the advancements supporting economic and innovative growth. So the question I ask often myself, could connected care be the two most important words in the next century? We've often talked about remote patient monitoring. And remote patient monitoring can be the Midas touch. It can enhance the care coordination between a complex ecosystem of various stakeholders. It can enhance the customer experience. It can improve efficiency, optimize spend with outcomes, as out-of-pocket spending is still very, very high in our country, outcomes with other countries. Though India provides a high volume care, but still keeps a high base of value care. Information availability and accessibility to patient and family can be made easier, and expand customer and clinical access to the entire ecosystem. So remote patient monitoring, connected care will be the two words we are going to often hear, and we have to manage the change accordingly in our ecosystems. We have seen a tectonic shift in doctors' behavior. There was a survey done in Smart Tech. 95% of clinicians who responded to the Smart Tech survey alluded to a behavioral change on a tech adoption driven by the unprecedented changes in the last 2 years. What has further helped are some key ongoing transformation factors of the healthcare technology industries. As I said, if you can see in the last survey, clinicians are embracing technology like never before. Government, with the National Digital Health Mission and teleconsultation guidelines produced in 2019, there is a lot of policy impetus during these trying times. And the industry has supported with the continuing investment momentum. This makes a strong case for technology adoption and transformation in digital healthcare and technology industry. We at Apex Hospital, under the banner of Hopes, have also done our bit for the society with the Indian School of Business. If you can see, there is a huge disparity between the population and ICU bed availability in the rural areas. That makes the case for remote patient monitoring, tele-ICU care, connected care, and this can be one of the only solutions which can be provided to the rural areas to overcome the challenges that we have talked about till now. And the mission is to take our expertise, provide critical care in the rural areas so the people don't have to overcome the challenges to come to the urban areas. And there is a significant economic benefit of living in the rural areas, living in the societies where the healthcare providers can provide tele-ICU care to these patients. So we mapped a lot of districts of Rajasthan. As you can see, there are significant amount of disparity between the number of population, the number of beds available, but we can overcome all these challenges by tele-ICU care. It can standardize the outcomes. It's 24/7 service. It can go directly to the customer or the healthcare provider. It can benchmark all the healthcare outcomes gradually, and the time for adoption is now. So what do we do in Delhi ICU? We are often understood as the second set of eyes. There is a 24/7 advice, assistance by the critical care experts from a command center, which is located in an urban area. There is often algorithm-based and protocolized care. Tele-advisory is provided for every patient, and there is a constant communication. Initial assessments of all these patients at the remote location is done, and there is a continued support not only of intensivists which manage the critical care, but a lot of super specialists which can provide care to a remote location from where we are sitting in an urban area. How do we do this? We have a patient in the ICU. There is a command center, as I said, and there is information technology devices like IoT integration devices. One command center can be readily scalable. It can see the patients, it can assess the patients, it can give protocolized care at the right moment to the right patient at the right time. Every patient will have a trajectory of care. Most of the patients, if assessed with protocolized care, get better. So patients are in ICU in a remote location through information technology devices and through a robotic cart. They are connected to the command center. Command center with the process flow, with the data available to them, sees them, initially assesses them, communicates to the team where improvisation can be made and protocols can be applied. There is a constant engagement with the remote site, and about 60 to 70% patients can be treated in remote areas. As you can see from the IoT device, this data flows through seamlessly, and it has become very, very easier because of a lot of policy impetus, software being developed, internet connectivity becoming better, and change management in the last 1 or 2 years, which has happened and helping us adopt all these technologies. This addresses the entire ecosystem. Information on one single platform can be shared between the healthcare providers, the patients and the family, and through the clinical decision makers. How do we do it? So we have a robotic cart, we have a remote ICU, and we have centralized monitoring. All three are seamlessly connected. It is not only the protocolized care, it's the constant communication, which also helps to streamline this process, minimize the knowledge-based gap, and align to better patient outcomes. What have we seen? What Delhi ICU can do? It can rapidly scale ICU capacity. There is a consistency in treatment with the round-the-clock availability of intensive care support. By beat-to-beat monitoring and protocolized care, we often don't leave or reduce the amount of errors that can be done. There is online training and remote support. You can often see with all these services being deployed in the remote areas, there is about 10% reduction in hospital-acquired infections. There is reduction in average length of stay, which for a volume-based country like ours is very, very important. There is reduction in the number of ventilator days with protocolized care and kind of the support that the command center can provide. And there is a significant reduction in mortality because of initial assessment, rapid action taking, consistency in treatment, and follow-up. So, as we discussed, remote patient monitoring and connected care via Tele ICU. What can it actually achieve? It can improve quality of care, that is, cannot be doubted. It can reduce the risk of infections, as also said in the last slide. It can engage with long-distance providers and patients. Often people don't want to travel to urban areas, leave their families and communities to get access to treatments. Easily reduces the burden on other parts of the healthcare system, like ambulance services, government hospitals, and ease the workflow with constant communication with the command center. And undoubtedly, it's significantly cost-effective. So, as I said, remote patient monitoring, there are few travel-related costs, less out-of-pocket costs. Less time missed at home, people recover better, stay in their community, and the economic benefit of staying in the community for a family and a patient is huge. And parallelly, we are developing resources in the community and upgrading the skills of the healthcare providers in the community as well. The cost effectiveness helps care provider by in-person visits, reducing the hospital readmissions, and relocating patients to urban areas. Just going to take you through numbers. So healthcare system saving from remote patient monitoring can be widely apportioned to about 2% to about 60% saving in the healthcare systems. One study has shown 3.5% saving on patient travel, 53 to 62% decrease in overall hospital admissions, though this data is based widely on cardiovascular diseases and chronic conditions. It can be seen over the years that Delhi ICU care will also make a dent in the urban admissions and increase the level of outcomes in the remote locations with the consistency with the technology that we are providing right now. So in the end, I would only like to say that patients deserve similar amount of care wherever they access the healthcare ecosystem. We have the ecosystem, we have the intention, we have to address the entire ecosystem. The entire ecosystem we have to bring together to have innovative ideas like Delhi ICU so that remote access and connected care can be the new two mantras to take us to a universal healthcare delivery, which is a dream of our Prime Minister. Thank you very much.
Thank you, Dr. Shailesh sir. It was very inspiring about the Delhi ICU and what HOPES is doing. And we have been working with Dr. Shailesh and Apex Hospital for quite some time. We have been partnering with them on how to take the Delhi ICU partnership. So basically, as you know, GenWorks is one of the leading healthcare solutions provider in the country. And we have been one of the strong players in intensive care area and critical care area. But what we have seen is, even though we equip a lot of hospitals with ICUs, we still see there are a lot of challenges, especially in tier 2, tier 3 cities. And basically, what we see is that mainly, there is lack of skilled staff and lack of limited availability of critical care specialists. And also, it's just not only critical care specialists, it is also the multi-specialty clinicians. Because what happens is, like Dr. Shailesh sir was saying, when you have a patient who's in ICU, you need, the patient can develop any kind of complication. You need probably neuro specialist, you need cardiology specialist, you need nephrologist, you need a lot of other related super specialists and specialists who may not be available in that particular city or particular town. And even if you have best-in-class monitor or ventilator, with the non-availability of this critical care specialist or super specialist, multidisciplinary super specialist, may be really creating a big gap in treating those patients. And with this, a lot of medical errors, wrong diagnosis can happen. And if they have to transport these kind of patients who have developed multiple organ failures or who have developed multiple complications to large cities, it's going to be a nightmare. So even though hospital can spend money and buy equipments, there are still a lot of challenges which can be limitation in developing the best-in-class critical care and intensive care facilities in tier 2, tier 3. So what do we need? We need integrated and centralized remote ICU specialists because it can be remotely monitored. There are a lot of companies today, or a lot of solution providers who have come up with remote ICU monitoring facilities. So, but some of them, we know they have an office space and they have a small group of trained intensive care doctors who sit and remotely monitor the patients. But that is sufficient for certain areas and certain patients. But what about if the patient requires super specialist support, or if they require immediate attention from any of the specialists? So then that will be a challenge. So you need not only critical remote ICU specialists, you also need multidisciplinary, multi-specialty clinicians. So, and also you need ICU staff trained and constantly being mentored to take care of the critical care patients. So these are some of the solutions what is required to build a good intensive care facility in tier 2, tier 3 space. So what GenWorks is doing, GenWorks, how GenWorks is helping in providing the tele-ICU support. So we provide infrastructure support to the existing hospital to build an ICU, or we can provide infrastructure support to build a new ICU. And it can be whether it is in existing hospital or in a new hospital. We can support in providing the human resources, interaction with ICU clinicians, ICU staff, shared resources, training them, and even providing connectivity to the leading academic institutions for doing training programs. And we can provide all the equipments required for ICU, building an ICU, and financing, and even pathology services and outsourcing some of these services can be done. We can support the hospital in completely providing them with pharma, consumables, and bringing them the supply chain from one place, GenWorks. And also we can provide them with best brands, even if they are located in tier 2, tier 3. They may not have access to some of the best pharma or consumable brands. So we can provide them with access to the best brands. And by consolidating all these things, we can bring down the cost. Cost of treatment can also come down very much in this areas. Training the staff is another priority area which we can support. Training the staff, training the doctors, and providing the digital platforms, tele-ICU platform, and technology services like providing them with remote connectivity and integrated care. And also the digital marketing support to reach out to patients, to keep the patients informed, relatives informed about the patients, and all these activities can be made available in a remote hospital. And also the specialist support where connectivity with intensivists, and Dr. 𝐂𝐍𝐶 sir was saying how it helps in remote specialist support. So we support in that consultation monitoring by multi-specialty clinicians, and of course finally the tertiary care. So if the patient has to be stabilized and transported to another care, another hospital, so we can help them to connect. So basically we bring the expertise in providing the complete support for building this remote ICU. And so we partner with HOPES and Apex Hospital and Dr. 𝐂𝐍𝐶's team. We work very closely with them. So what we are doing is GenWorks and HOPES jointly are building this remote ICU capacity. So we can build an ICU in any tier 2, tier 3 hospital and connect them to Apex, and the doctors, ICU specialists, super specialty, multi-specialty specialists sitting in Apex Hospital can remotely monitor the patients in any city, anywhere in the country. It can be even within the country or outside the country. And we provide equipment, devices, technology, consumables, pharma, the relationship, and the commercial models. Whereas Apex hopes they bring in clinical expertise, patient management and care area consultation, protocols and training. So combining these two, we provide the end-to-end solution to the tier 2, tier 3 hospitals. So basically this is how we partner, and we hopefully provide a complete care and bring the best-in-class intensive care, critical care, specialization in every corner of the country. That is what GenWorks is for, to build a healthier India. So thank you so much. Thank you, Dr. Shailesh sir, for the partnership, and thanks for this opportunity. Thank you.